I'm Peter Block here in New Orleans at the AHA annual meeting. So I'm going to ask the question, PIONEER, PRECISION, and EUCLID, three major trials that came out of this meeting. We're talking about the important stuff that we've learned here in New Orleans. With me on the left is Kim Eagle, needs no introduction. In the middle is the second amigo, Deepak Bhatt, also no introduction. So I'm going to throw this one to Deepak. PIONEER, Deepak, give us the word and also give us the take-home on this one.
Sure. Well, first of all, I think it's a terrific study and perhaps the most practice-changing study from this AHA. This was a trial, common clinical situation, patients with AFib getting PCI. What do you do with them? And the trial randomized patients to one of three strategies: conventional triple therapy, that is aspirin, clopidogrel, full dose warfarin, or one of two experimental strategies, rivaroxaban 15 milligrams a day plus clopidogrel versus aspirin, clopidogrel plus very low dose rivaroxaban 2.5 milligrams twice a day.
And we know in the past that warfarin has always been a bad actor, right? Triple therapy with warfarin just isn't really terrific.
Doctors don't like it, patients don't like it, and what this trial showed was that triple therapy is a bad player. So the rates of bleeding were significantly higher in the conventional triple therapy, that is aspirin, clopidogrel, full dose warfarin arm. In fact, that was the paper published in New England Journal, but in Circulation, and I wrote the editorial in Circulation, there they actually examined the composite of mortality and hospitalization, and that was significantly reduced in both of the rivaroxaban arms versus the warfarin arm. So really important findings,
This is really a game changer, I think, because we've been stuck with warfarin and the dual antiplatelet story, and now this will probably be the first of several trials where the novel oral anticoagulants will come into play and it'll really help our patients
I'm sure
a lot.
we'll see this with the other novel anticoagulants as well, but the fact of the matter is warfarin's gone for my patients anyway, and that really helps.
Me too.
Totally.
It's practice changing.
Yeah.
And you know what was interesting here was I mentioned hospitalization, but it was hospitalizations for bleeding that were reduced with the two rivaroxaban arms. It was also hospitalization for cardiovascular events that was reduced.
Yeah. And the cool thing is, if you have a high-risk patient, you can give the low-dose rivaroxaban, and if you have a reasonable patient that probably is not going to bleed, go ahead and give them a little extra rivarox. So I think this is all good news and easy to deal with for folks out there taking care of AF patients who need stents.
Yeah, absolutely. Just the one cautionary note for folks that aren't as familiar with NOACs, rivaroxaban is renally cleared. There was a dosage adjustment from 15 milligrams to 10 milligrams in the double therapy arm. And it's a 20 milligram dose that one would use as monotherapy for AFib. So these are lower doses than one uses for AFib.
Okay, moving on. Euclid. Kim, it's up to you.
It was a study looking at a randomized trial of patients with peripheral arterial disease, clopidogrel versus ticagrelor. And even though ticagrelor certainly in the coronary circuit has shown some advantages, in this particular trial, clopidogrel was every bit as good as ticagrelor in this group of patients in peripheral arterial disease. So it's simpler. Life is simpler for us with clopidogrel in these patients that are high risk.
Yeah, absolutely agree. And just to clarify, it's the Euclid trial, but peripheral artery disease patients, clopidogrel monotherapy versus ticagrelor monotherapy, and clopidogrel looked as good, and it's cheaper, it's once a day, a little less bleeding, less dyspnea, so good old clopidogrel won that one.
You know, clopidogrel came on the scene and everybody jumped up and down and said, what a great drug, this is awesome. Now all of a sudden clopidogrel is not such a great guy anymore. The fact of the matter is it is.
Yeah, in the right indications, it's pretty good.
It's standing the test.
Yeah, okay. So which is the third one of this? We have
Precision.
Precision, exactly. Yours.
Sure. So Precision was, I think, a really important trial, large study of patients that were on different means of pain control. So, what do you do in real life? Somebody's got arthritis, and you could use NSAIDs, but they've got all sorts of concerns about cardiovascular and GI and renal toxicity. Or you could use a COX-2 inhibitor, such as celecoxib, as was used in this trial. But as everyone knows, there were concerns about COX-2 inhibitors potentially causing problems. That was really an issue with rofecoxib. The question remained, was it true of celecoxib? And in this trial, the two NSAID arms, the two conventional NSAID arms, looked worse than celecoxib. That is, celecoxib didn't have any cardiovascular risk excess compared with the NSAID arms, and there was less GI bleeding and less renal events. So overall, it looked like a win for celecoxib.
Sort of, right?
So what's the dosage?
So an issue that came up that the discussant brought up was that is it comparing apples to apples? That is, was the dose of ibuprofen much higher than sort of an equivalent dose of celecoxib? Was it an unfair comparison? The other issue that was raised is there was a fair amount of missing data. As far as the missing data issue, tough population, right? This isn't a cardiology trial. This is pain control. If a patient's having pain, you can't say stick with the randomized therapy, right? You've got to do what you've got to do. The dosing thing, one can argue what the exact doses should be, but overall, I thought that whereas there were concerns about celecoxib before, perhaps they're less now. But maybe you thought differently.
No, I think you're right. I think we've seen patients with high dose celecoxib who had hypertensive crisis and concerns about stroke and things like that. In lower dose range, this trial suggests that it's not too dissimilar from traditional NSAIDs.
Yeah, but the other side of this is that these were patients who were really in pain, right? These were bad osteoarthritis patients.
Right.
They had to take prescription type drugs in order to control their pain. And for all of us out there that have a little back pain, or have a little joint pain, or whatever, sore muscles, you can probably take a little Aleve every once in a while, and it isn't terrible for you. But if you take high doses of it for a long time, probably not a good idea.
Agreed.
Yeah,
I think that's the
absolutely.
main message here, right?
I think it's a good message, and that there's a lot of GI toxicity. That is, despite PPIs and other protective strategies, the NSAIDs were causing a lot of GI bleeding. So, but I agree with you. Not any one trial can answer every question, and there's no placebo arm. There couldn't have been a placebo arm in this sort of trial, so it doesn't say that celecoxib is as safe as a placebo. But certainly in the context of other commonly used drugs in arthritis, no smoking gun as far as it being
I agree with you.
Unsafe.
All right, so we all agree, and that's unusual.
That's amazing.
That is.
Yeah.
Holy cow.
Who
We better
knew?
find something to disagree about.
Okay, maybe next time.
Maybe.
Thanks, everybody.